Hello everybody, I'm Dr. Sitara M. Medhar, Senior Resident from Department of RadioDiagnosis at Sri Siddhartha Institute of Medical Sciences, T. Begur. Today I will be making a presentation on mirror image malignancy, which was a diagnostic conundrum seen in our Department of RadioDiagnosis. The patient presented with a clinical history of 66-year-old female who had come with history of mass per abdomen, which was gradually increasing in size over the last 6 months. She presented to the Department of Obstetrics and Gynecology with this complaint. On examination, they found that there was a mass per abdomen that was extending into the pelvis, and there was fullness of both vaginal fornices on per vaginal examination. Serum CA125 levels were done, which were around the range of 1125 international units. So she came to us with this for an ultrasound of the abdomen. On ultrasound, we found in the right agnesa a large heterogeneously hypoechoic mass lesion, which was measuring more than 10 centimeters in size, which was seen to be extending up to the midline and had cystic areas with solid hyperechoic contents, which was not seen separately from the right ovary. The cystic component showed multiple internal septations, and this is the image of that lesion, which shows a large multicystic mass lesion, which shows internal vascularity within the septations, and which has a large solid component, which is seen as hyperechoic. In the left adnexa, similar morphology lesion was seen, which was predominantly cystic, which was also more than 10 centimeters in size, which had a large eccentric solid component. Here you can see a large cystic lesion, which has hypoechoic anechoic cystic area with a large mural nodule, which is hyperechoic. Based on these images, we looked for other findings that would help us make the diagnosis, and these were some of the negative things that we did not find in this patient, which included free fluid in the peritoneal cavity, fishnet appearance of the septations, ground glassing or layering of the fluid within the cysts, and no hyperechoic foci with posterior acoustic shadowing, which might suggest coarse calcifications. So the diagnosis that we finally reached was ORADS. We used the system known as ORADS, which is ovarian and adnexal disease diagnostic system. And in our patient who had all of these key characteristics, that is multicystic lesion, multilocular cysts, solid component which had vascularity, size is more than 10 centimeter, and ovarian origin. In a postmenopausal woman, the diagnosis of ORADS USG4 was reached. So the next step in this would have been an MRI and a gyne-oncology referral. So on MRI, what were the things that we found? This is a representative image of a multicystic ovarian lesion seen on MRI. On the right hand side, you can see in the A image a large cystic lesion, which is T2 weighted image, in which the contents of the cyst is appearing as hyperintense, while in the T1 weighted image, you can see in the axial section that the lesion is appearing hypointense with multiple other intensities noted within. This is because of the multicystic nature of the lesion. Then this is an example of a cyst with mural nodule seen on MRI. In the T2 weighted image, the cystic lesion is appearing as hyperintense with a mural nodule which is hypointense. And in the T1 weighted fat saturated image, you can see that the solid component is hyperechoic while the fluid content is slightly hyper intense. And in the contrast images, you can see that the solid component is enhancing. So what are the differentials when you see such a cystic lesion in the bilateral ovaries? The first will always be a mucinous or a serous cystic lesion of the ovary. The next will be something that is more benign, such as a functional ovarian cyst, or something that is para-ovarian, such as a para-ovarian cyst. So what is ORADS? ORADS is basically the diagnostic tool that is used to categorize the various lesions in the ovaries. It stands for Ovarian Adnexal Reporting and Data System, and US stands for ultrasound. So it has multiple categories such as 0, 1, 2, 3, 4, 5, in which 0, which means unknown, which means it requires further evaluation. 1, which means a normal ovary which can be seen as a dominant follicle or a CL cyst. 2 is almost certainly benign, which means that the percentage of malignant transformation is less than 1%. In this, we have examples such as simple cyst, classic benign lesions, non-simple unilocular cysts with smooth margins. 3 is low risk, which means 1 to 10% chance of malignant transformation. These include unilocular cysts that are more than 10 centimeters and multilocular cysts which are less than 10 centimeters in size with color score of less than 3. Then you have ORADS category 4, which means intermediate risk, that is 10 to 50% chance of malignancy. That includes multiloculated cysts with color score of more than 3, unilocular cysts with solid component, multiloculated cysts, solid component with a color score of 1 to 2, and some solid lesions. 5 category 5 is high risk, which means more than 50% chance of malignancy. These are some of the examples of classic benign lesions that are seen. This comes under category 3, category 2, classic benign lesions. Here you can see that there is a cyst. This is a cyst with a hyperechoic content and fishnet appearance. This is an example of a hemorrhagic cyst with retractile clot. Here you can see a cyst which has a solid component which is showing posterior shadowing. This is an example of a dermoid cyst. The third image on the extreme right, you can see a cyst which has layering of the fluid and ground glassing. This is an example of an endometrioma. Here you are seeing a cyst that is seen separately from the left ovary. This is an example of a paraovarian cyst. Here you are seeing an image of a cyst that is surrounding the uterus, and the fluid is seen to surround the uterus. This is an example of a peritoneal inclusion cyst. The last image on the right hand side shows a cyst which has an incomplete internal septation, which is an example of a hydrosalpinx. These are certain classic benign lesions which are not come under ORADS category 2. They are non-malignant. So this is a tabular format in which you can use to categorize the lesions based on what category they fall under based on certain imaging findings. The first thing is whether it is a classic lesion or it is a non-classic lesion. Any classic lesion which is less than 10 centimeter will automatically come under ORADS category 2 as indicated by this image. Then if the classic lesion is there but it is more than 10 centimeters, then you will go for ORADS category 3. Why are we categorizing it as ORADS category 2, 3, 4, 5 is because of what we are supposed to do next. So in ORADS category 2, the only thing we will do is follow up. In ORADS category 3, some persons such as postmenopausal women or women with high risk, such as those who have had relatives who have malignancy, they will undergo MRI pelvis and further evaluation. So next comes the non-classic lesions. In non-classic, there is cystic lesions and solid lesions. In cystic lesions, there are certain simple cystic lesions. Simple cystic lesions meaning thin wall cysts that have very few septations, very thin septations, no vascularity within either the cyst, within the wall of the cyst or within the septation. That is further classified based on the size criteria. So less than 3 centimeters, nothing is to be done. If it is more 3 to 5 centimeters, you will follow it up. If it is 5 to 10 centimeters, if it is a postmenopausal woman, you will follow it up in 1 year. If it is premenopausal woman, then you will follow it up in 8 to 12 weeks. Then if it is more than 10 centimeters, it comes under ORADS category 3, which means that you will send her for MRI, pelvis and gynae oncological referral. Then you have a non-simple cyst in which it can either be unilocular or multilocular. Unilocular cysts are basically cysts that have single locule, may have some incomplete septations or can have a small mural nodule within. This again is categorized based on whether the inner wall of the cyst is smooth or irregular. If it is a smooth wall cyst less than 10 centimeters, nothing else to be done except follow up. If it is 3 to 10 centimeters, then either you will send her for an MRI if she is postmenopausal, or you will follow her up in 8 to 12 weeks if she is premenopausal. If it is a smooth walled cyst which is more than 10 centimeters, it is categorized as ORADS 3, and irregular inner wall cyst which is unilocular again comes under ORADS 3. Then if the unilocular cyst with a solid component is there which has vascularity or papillary projections in the number of 0 to 3 are considered as ORADS 4, while more than 4 papillary projections are considered as ORADS 5. Finally, coming to the multilocular cysts, you have smooth inner wall and irregular inner wall similar to this cyst. Again, you will categorize it based on the color score of the wall component, and if it is color score is 1 to 3 and size is less than 10 centimeters comes under 3 ORADS 3, and if it is 1 to 3 color score with size more than 10 centimeters, it comes under ORADS 4. Finally, we are coming to the color score of 4 or irregular smooth inner wall with color score of 4, or irregular inner wall with solid component which has color score of 1 to 2, it comes under ORADS 4. While if it is a multilocular cyst with color score of more than 3, then it comes under ORADS 5. Solid lesions, if it is a smooth external wall solid lesion, then you categorize it based on the color score. If it is color score of 1, it comes under ORADS 3, color score of 2 to 3 comes under ORADS 4, and color score of 4, it comes under ORADS 5. If it is an irregularly marginated solid lesion, directly it will come under ORADS 5. So what is this color score that we are talking about? We will come to that soon. What are certain benign characteristics that we mean that the lesion does not need to be further intervened. So see, these are some of the benign characteristics that can be seen. That is a unilocular cyst with a small solid component, a unilocular cyst which has posterior acoustic shadowing. This means that that's a calcific focus, which is a coarse calcification, and it is casting an acoustic shadow. Then you have a smooth multilocular cyst, but the walls are very thin and it is less than 100 mm, that is less than 10 centimeter size. That is also benign characteristic. And if there is no blood flow or color score is 1, that means it is a benign lesion. So this is what I mean by color flow characteristics. The minimum color flow, either this is a solid lesion, this is a multicystic lesion without solid component, this is a multicystic lesion with solid components. So when I say CS1, that is color score of 1, it means that there is no flow, that is only flow within the wall of the ovary. This is the ovarian stroma, and there is only color flow within the ovarian stroma. While minimal color flow means that some of the components are taking up color, while majority of the components are not taking up color. While color score of 3 means it is moderate color uptake, that is majority of the area is taking up the color, while color score of 4 is very strong flow, which means that most of the lesion is taking up color flow, as you can see in the last images. Okay, these are certain malignant characteristics which will make us doubt what could the lesion be. So these are certain things that will make us very aware of what we should be doing next. So that is if it is an irregularly marginated solid tumor. If there is a lot of ascites, this is free fluid within the abdomen that you can see. This is the uterus and you can see free fluid within the abdomen. If there are papillary projections, these inner wall projections that you can see within the cyst are known as papillary projections. If there are more than 4 of such projections, that means that the lesion is likely to be malignant. Finally, you have an irregular multicystic lesion which is more than 10 centimeter in size, or if the lesion has a color score of 4. Coming to the differential diagnosis in our case, so what is an example of what are the things that it could have been? So functional ovarian cysts are very small in size. They're usually seen in premenopausal women. They don't show any vascularity. They're very thin walled. They don't show any, they might show some daughter cysts or cyst within cyst appearance. All of these characteristics, if present, would have indicated that this lesion was a functional ovarian cyst or a benign lesion. Next differential was a paraovarian cyst. Since in our case we saw the lesion, the cyst along with the ovary, and it was not seen separately from the ovary, this has majority been ruled out. However, since it is a cystic lesion, this can also be one of the differentials that it could have been. So these are usually thin walled. They are more likely to be unilocular rather than multilocular. They are thin walled. They don't have any, they are seen separately from the ovary. They are seen to move separately from the ovary, and they may show this beak sign, which means that the organ of origin lies outside of the ovary. Third is a mucinous cystic lesion. Majority of mucinous cystic lesion are seen in the perimenopausal age group, that is 40 to 50 years of age, and they are more likely to be multilocular with small cystic areas rather than multiple large cystic areas, and it can have honeycomb-like locules. On MRI, you are seeing something known as a stained glass appearance due to the variable quantity of mucin in each of the locules, which means that it appears as a stained glass. And finally, coming to the serous cystic lesion, which is more likely to be unilocular, more likely to be bilateral, more likely to have papillary projection and solid components. and it can have associated ascites and lymphadenopathy. All of these features will indicate that it is rather more likely to be a malignant serous cystic tumor rather than a benign serous cystic tumor. In our case, the histopathology finally came as bilateral serous cyst adenocarcinoma of both ovaries. So this was one of the things that appeared to be something else in the beginning and turned out to be something else in the end, and it was similar grade of lesion in bilateral ovaries. So it was a very interesting case for both us as well as the treating physicians to find. These are my references. Thank you so much.